Okay, so this is the second part we'll be going over for esophageal disorders. If you didn't watch the first part yet, that's up on YouTube. You can take a look at that first. But the second part, we're going to be going over hiatal hernia, Zenkers Diverticulum, Mallory-Weiss Syndrome or tear, Boerhaave Syndrome, Esophageal Varices, and Esophageal Web and Ring. I just wanted to thank those of you who have been leaving me reviews, comments, and things like that, like my videos. I absolutely appreciate that so much. It just lets me know it is helping you, and I just wanted to thank you again for that. So let's go ahead and get started. The first thing that we're going to go over is hiatal hernias. This is a pretty important one for the pants in your exams. This is going to be when a portion of the stomach herniates or slips through a portion of the diaphragm known as the esophageal hiatus. Now there's going to be two different types that you need to know of, and that's going to be sliding or type 1 and then paraesophageal type 2. So starting with sliding or type 1, this is going to be your most common type, so this is going to be the one that you should really be familiar with. This is going to be when the gastroesophageal junction, which is going to be in between the esophagus and the stomach, the junction there, is going to herniate straight up into the mediastinum. So just to take a look here, this is going to be your normal esophagus and stomach, diaphragm right here. Now a sliding hiatal hernia, which is the one we're going over now, is going to be the gastroesophageal junction is going to herniate straight up here. Paraesophageal, we'll go over that in a minute. That's going to be the fundus going up. But this is the one we're talking about right now. So you can take a look at what that looks like. And again, this is going to be your most common type. About 90 to 95% of patients are going to have a sliding or type 1. So by far, most common type. Patients, most of the time when they do have symptoms with this, they're going to present with GERD symptoms. Now, why do these patients have GERD symptoms? Well, what you need to understand again is that the gastroesophageal junction, including the lower esophageal sphincter, is going to herniate straight up and away from the diaphragm. Now, why is that important? Well, the lower esophageal sphincter and the diaphragm actually work in this synergistic way where the diaphragm actually augments and increases the strength of the LES. So when the LES is being pushed away from the diaphragm, it doesn't have that extra strength of the diaphragm pushing and keeping it clamped shut, keeping that gastric acid out, and this can lead to reflux and GERD symptoms. So that's why in sliding type 1, you'll see those GERD symptoms. Now, paraesophageal or type 2, just as a side note here, it's not only type 2, it also includes type 3, type 4, but type 2 is the one you'll hear talked about the most, and that's paraesophageal, not as common. This is going to be where the fundus of the stomach instead of the gastroesophageal junction, so the fundus is going to herniate through the diaphragm. And again, looking at the diagram here, or the diaphragm, I'm sorry. So the stomach here, you have the fundus of the stomach, and it's herniating through the diaphragm. So away from the esophagus here, it's going to be the fundus herniating through the diaphragm there. Now this one, normally patients are going to be asymptomatic, but what you do need to know about a paraesophageal hernia is that it can lead to some complications that you won't see in type 1. So these patients may develop gastric volvulus obstruction, a lot of problems that can be pretty serious that you won't see in type 1. So we do need to treat a little bit more aggressively, which I'll go over that in a minute. So as far as the diagnosis for both of these, you're going to use barium esophagram for both. It's going to be your most sensitive diagnostic test. That's going to be the one you need to know for your boards, for real life, also known as a barium swallow. So this is what that's going to look like when you actually do a barium swallow. Barium coming down the esophagus here, and then you'll see the gastroesophageal junction, like in a sliding. Right here, you see this herniated portion of that junction right here. So that's what that's going to look like in these patients on exam or on imaging. Treatment depends if it's a sliding type 1 or type 2. So sliding type 1, pretty straightforward. You're basically just going to use PPIs to treat their GERD symptoms. There's really no complications with this for the most part. So there's not too much else you need to do. You're going to have them lose weight, because weight loss, obesity increases the intra-abdominal pressure, which can worsen the hiatal hernia. So you do want them to lose weight, and then you just want to treat their GERD symptoms, but not too much else besides that for a type 1. That's really all you need to know. Now, type 2 or paraesophageal, remember you do have some of the complications with these patients, so you do need to consider that. If they're asymptomatic, most of the time you'll just observe, but it is a little bit controversial because you do need to consider that if they do wind up having a gastric volvulus obstruction, it can be pretty severe in these patients, and they can, a lot of times have a lot of severe problems from this. So in some asymptomatic patients, some literature suggests having them actually have surgery to correct it, but most of the time, most of the suggestions are just observation. But if they do become symptomatic or they develop complications, absolutely you want to go through with surgical repair for these patients in paraesophageal or type 2. Now, I'm going to start putting need to know things for all the diagnoses that we're going through, because there's a few things I feel with every disease. There's like maybe 2 or 3 things that you absolutely have to know. So for hiatal hernia, the 3 things I think you need to know is that first, that there's 2 types, again, sliding and type 1 or paraesophageal and type 2. You need to know that type 1 is going to be your most common type, about 90 to 95% of patients. And you need to know that paraesophageal can lead to complications such as volvulus or obstruction. That's a little bit more serious. Now moving on to Zenkers diverticulum. Zenkers diverticulum is going to be this false diverticulum or outpouching of the mucosa and submucosa through a weakened area of the junction of both the pharynx and the esophagus, which is known as Killian's triangle. So remember that term, Killian's triangle. This is what it's going to look like. So you have where the pharynx and the esophagus is meeting here. This is the weakened area here, the Killian's triangle. And then you have this outpouching coming from the posterior edge of the esophagus, which is could potentially collect food, lead to dysphagia, which we'll go over in a minute. But that's what that looks like with a patient that has Zenkers diverticulum. It's most common in males, about a 1-to-5 ratio. And then it's also going to be common or more common in patients in their 7th and 8th decade of life. So patients in their 70s and their 80s. As far as clinical manifestation, a lot of times if they're a small diverticula, these patients are going to be asymptomatic. But when it does become larger, they're going to have dysphagia, so they'll have some trouble swallowing. And then the key term, the key thing that you need to know that you're going to see in a vignette that's going to help you differentiate this between other causes of dysphagia is halitosis. Absolutely need to know that. So if you remember the diagram from before, you saw this outpouching. So essentially a pouch sitting at the back of the esophagus, and when it gets large enough, food literally gets caught in this pouch and sits there and ferments, which can lead to halitosis. Sometimes these patients will regurgitate up the food as well, but you need to know halitosis. That's going to absolutely be in the vignette, and that's how you're going to know that it's Zenkers diverticulum rather than some other cause of dysphagia. So remember halitosis, that's really important. Diagnosis is going to be a barium swallow or barium esophagram again. So it's going to show barium collecting at the posterior edge of the esophagus. This is what that's going to look like. Here's the barium going down the esophagus, and then here's the portion, the posterior edge, getting caught in the diverticulum. So that's what that's going to look like on imaging. Treatment, again, if it's asymptomatic, if the patient's asymptomatic, it's a small diverticula less than a centimeter. You're just going to observe. It doesn't really warrant any treatment. If it is larger or these patients become symptomatic over a centimeter, you're going to do something called a diverticulectomy, which is a surgical procedure to remove the diverticula. It's typically minimally invasive. They use a transoral endoscopic approach, and that's just to remove the diverticula. So again, that's Zenkers diverticulum. What do you need to know? You need to know that this is a false diverticulum at a weakened portion at the junction of pharynx and the esophagus, known as Killian's triangle. You absolutely need to know that this patient will have halitosis when it becomes larger, so you need to know that for the vignette. And then you need to know that barium esophagram is going to be your test of choice. So that's Zenkers diverticulum. Let's move on to something known as Mallory-Weiss syndrome or Mallory-Weiss tear. This is going to be a longitudinal mucosal laceration of the distal esophagus and proximal stomach. Now you need to know there's no perforation. It's a partial thickness laceration. It's not going all the way through the esophagus. And this is important because Boerhaave syndrome, which we'll go over next, is a transmural going all the way through the esophagus, and you need to know the difference between them on a vignette because you will definitely have both as an answer, and you need to know which is which. So this is what this looks like. Mallory-Weiss tear is going to be these small superficial lacerations in the esophagus. So that's what that looks like there. As far as the cause, this is another one of the things you have to know. Most common cause of Mallory-Weiss syndrome is going to be after an alcohol binge leading to excessive retching and vomiting. And this is going to be about 80% of patients with a Mallory-Weiss tear or Mallory-Weiss syndrome have a history of alcohol use and excessive retching and vomiting. That's one of the things that you need to know for the boards. It's going to be on the vignette, and that'll help you differentiate. So alcohol binge leading to excessive retching and vomiting, Mallory-Weiss syndrome until proven otherwise. With that history. Clinical manifestations, well, depending if they do have an actual rupture of a submucosal artery, they may have an upper GI bleed with hematemesis. They may have some epigastric and back pain due to the laceration. And then if they're losing a significant amount of blood from if there is a rupture, they may be hypotensive, hypovolemia, tachycardic, presenting with those symptoms because of the volume loss with these patients. Diagnosis is going to be an upper endoscopy to identify the laceration and treat the ruptured artery. And then as far as treatment, it all depends. If these patients are bleeding, if they did have a ruptured artery, you first need to stabilize them. So you're going to stabilize them with IV fluids, blood transfusion, and then if the second step, of course, would be for to use endoscopy to locate and treat the active bleed, to treat the active ruptured artery. Now, if they're not bleeding, what's important here is that you want to make sure that these patients have some form of acid suppression with PPIs. Now, PPIs help promote hemostasis by neutralizing gastric acid. They can stabilize blood clots. They're normally used for about 2 weeks after a Mallory-Weiss tear. So that's important for to help these lacerations heal. Acid in the area is not going to promote healing of these lacerations, so they do need PPIs for about 2 weeks. And then if they're actively vomiting, you're going to use antiemetics like metoclopramide, ondansetron, etc. if they are still vomiting when they do come in to see you. So the two things that you really need to know for Mallory-Weiss syndrome is that it's a superficial mucosal tear of the esophagus. It's non-perforating. And then you also need to know, 100% need to know that this is going to be most common cause is going to be retching and vomiting after an alcohol binge. That's really important for Mallory-Weiss syndrome. Mallory-Weiss tear. Now, this is going to be the opposite end of the spectrum. This is going to be Boerhaave syndrome. And now Boerhaave syndrome, Mallory-Weiss tear was a superficial laceration. Boerhaave is going to be ripping right through the esophagus. This is going to be a full-blown perforated esophagus. So full thickness rupture of the esophagus associated with high morbidity and mortality can be fatal without intervention. So this is a lot more serious than a Mallory-Weiss tear. Now, how do I remember the two? So what I've come up with here is Mallory-Weiss syndrome or Mallory-Weiss tear. A little girl named Mallory. So Mallory can't do much damage to your esophagus. She's just a little girl. She can only cause a partial thickness tear of the mucosa and submucosa. Most of the time, the tears that Mallory causes are going to resolve spontaneously in most cases. Now, on the opposite end, if that's all Mallory could do, what is Boerhaave syndrome going to do? So Boerhaave syndrome is going to be this wild boar with these massive tusks that are going to rip right through the esophagus and cause a perforation. This is going to need emergent thoracic consult, much more dangerous. So you need to know this again, because when they give you a vignette, they're not going to give you just Mallory-Weiss syndrome. They're going to tell you there's a laceration, and then both of these are going to be in the answer. So if you remember, the boar is ripping through the esophagus. Mallory is just a little girl. She just causes a superficial laceration. You'll remember which is which. So that's how I remember that. As far as the most common area that you're going to see the laceration in Boerhaave syndrome, it's going to be the left posterolateral aspect of the distal esophagus. So that's the most common area that you'll see this laceration. Causes, there's a few more causes compared to Mallory-Weiss syndrome where you really just needed to know retching and vomiting. So it can also be caused from retching and vomiting with Boerhaave syndrome again, but it's not going to be your most common cause. More commonly, it's going to be an iatrogenic cause. So something that we did as healthcare providers, whether we were doing an endoscopic procedure and we lacerated, something that we did ourselves, iatrogenic. So more common than retching and vomiting. And there are some other less frequent causes, but anything that causes a combination of intraesophageal pressure combined with negative intrathoracic pressure. So anything you're basically like bearing down, squeezing, so prolonged laughing, coughing, weightlifting, childbirth, seizure, these things can all cause a Boerhaave syndrome. So that's important to know as well, that there can be some of these lesser, kind of obscure causes, but more commonly it's going to be iatrogenic or retching and vomiting. So some other ones that you need to know for that. Now in history and exam, these patients had full-blown laceration through the esophagus, a perforation. They're going to have excruciating retrosternal chest pain. So that's going to be one of the things you need to know. And then, but that's not so specific. There's a lot of things that can cause, bad chest pain. But some of the things that you need to know to differentiate is they may also have crepitus on palpation of the chest wall. Remember, you have the esophagus, which can release air and fluid and things like that into the mediastinum. So they may have crepitus on palpation. And then one of the key terms that you really need to know is something called Hammond sign. And this is going to be mediastinal crackling with each heartbeat. So remember Hammond sign. That's one of the ones that they really like to ask. You'll probably see Hammond sign. So remember, can be caused from Boerhaave syndrome. So real life, I just kind of wanted to mention things like crepitus on palpation of the chest wall, Hammond sign. In real life, probably not going to be so common. It's really only going to be seen in a small amount of patients. So, because it takes hours for these signs to present in an actual patient. And at that point, a lot of patients don't even make it to that point. But you do need to know for the exams, the boards, but just to know in real life that these things you may never actually really see in real life. Um, Moving on to the diagnosis. So for Boerhaave syndrome, again, you're going to do an esophagram, but the important thing here, very important, look at what I'm saying here, contrast esophagram. Now, before I would always say barium esophagram, barium swallow, because barium is your best contrast when you're doing an esophagram. It has the best contrast ratio. It picks up some of the more small imperfections in the esophagus. But in this case, because you suspect a perforation, you're no longer going to be using barium. You're going to be using something called gastrographin. And why do you use gastrographin in a suspected perforation? Well, a couple reasons. First, gastrographin is actually water soluble. So if you do have a perforation and gastrographin gets into the interstitial spaces and things like that, it gets into the mediastinum, it can actually be readily absorbed by the body, whereas barium cannot. The other thing is, if you give a patient barium that has a perforation and it gets into the mediastinum and pleural cavities, it's actually a caustic substance. So it can cause inflammation. It can cause all of these problems in these patients, and you just do not want it outside of the GI tract. So remember that Boerhaave syndrome, or anytime you suspect a perforation, use gastrographin with the imaging study rather than barium. And this is what that's going to look like. The patient swallows gastrographin, you have your perforation here, and it's just leaking out into the pleural cavity, into the chest wall, into the mediastinum. So you see all the contrast leaking out here. So that's how that's going to appear on imaging. You can also do a CT chest if you suspect any free air in the mediastinal area, also known as a pneumomediastinum. So you can do a CT chest to rule out that as well. But really, it's going to be your contrast esophagram to diagnose Boerhaave syndrome. Now, as far as treatment, remember, these patients, this has a very high mortality and morbidity rate, so you need to make sure you stabilize these patients first. So how do you stabilize patients with Boerhaave syndrome? There's a few things you need to do. So initially, IV broad-spectrum antibiotics. Why do we use broad-spectrum antibiotics? You have, again, a rupture of the esophagus, which is going to be releasing gastric contents into the mediastinum. These patients can quickly become septic, so they do need IV broad-spectrum antibiotics. Need IV fluids. Remember, they may become hypovolemic. They're losing a lot of blood. IV PPIs, remember we want to suppress that gastric acid, and then MPO, which is a little bit silly because most of these patients I can't imagine are going to be asking for anything by mouth or any food or drink within the situation that they're in, but you do need to know that that this is all going to be parental nutritional support with these patients. You don't want anything by mouth. Now, once they're stabilized, you want to go ahead and get a thoracic surgeon consult. Not in all cases will they need to go to the OR and actually need a surgical intervention. In some smaller lacerations with Boerhaave syndrome, sometimes stabilizing these patients is enough and just observe. And in some patients, they do need to go to the OR. They do need further treatment, whether it's an endoscopic approach using endoscopic suturing, resection, but you do need a thoracic surgeon consult regardless to see whether or not they need further treatment. So that's Boerhaave syndrome. Now, how do you what are the few things that you really need to know for Boerhaave syndrome? So you need to know it's a full thickness tear. Remember that bore ripping through the esophagus. You won't forget that. You need to know Hammond sign, mediastinal crackling with each heartbeat. And then you need to know that you're going to do a contrast esophagram with gastrographin rather than barium for these patients. So that's Boerhaave syndrome. Let's move on to something similar in the way that there is bleeding in the esophagus again, but not due to a laceration. So this is esophageal varices. And what esophageal varices is an enlarged or dilated veins in the distal esophagus, which is caused by portal vein hypertension. Specifically, the veins that are involved are the gastroesophageal collateral submucosal veins. And due to the high pressure in these veins, they're susceptible to rupture, which can cause, lead to these life-threatening upper GI bleeds. So there's, again, a really high mortality morbidity rate with esophageal varices, and it's something that you need to know in real life because these patients can crash on you very fast. So esophageal varices, what are the risk factors? There's one that you really absolutely need to know. It's another one of these need to know things. Cirrhosis is going to be your most common cause. Half of all patients with cirrhosis will eventually go on to develop esophageal varices. So you absolutely have to know that. And why does cirrhosis lead to esophageal varices? Well, cirrhosis causes scarring in the liver. that can cause obstruction of the vessels that flow through the liver. When this happens, blood flow can back up into other blood vessels nearby, like the vessels in the esophagus, which leads to these vessels engorging, causing increased pressure, and ultimately, in some cases, rupturing. So cirrhosis, again, most common cause. As a side note, this can be seen in children as well with portal vein thrombosis. Not as important. You really just need to know cirrhosis for esophageal varices. That's going to be your really big cause of this. Clinical manifestations, it all depends. If this is going to be a stable esophageal varice, one that hasn't ruptured, these patients are most likely going to be asymptomatic. They're not going to have any issues. But in a vignette, they're not going to ask you about a patient that has a stable esophageal varices. They're going to ask you about one that's ruptured. So what you need to know in a patient who had a ruptured esophageal varice, they're going to have a lot of things going on because there's this massive upper GI bleed. They're going to have hematemesis, so they're going to be vomiting blood. They're going to have melena because they're going to have all of this blood in the esophagus and they're going to be swallowing it. So it's going to lead to dark stool from all of this broken down red blood cells in the stool. So they may have melena, which that's what that's known as. And then, of course, from all the blood loss, they may have altered mental status, hypotension, tachycardia. They're going to be hypovolemic. So you need to know that as well. These patients are going to be pretty sick. So as far as diagnosis, you're going to use an upper endoscopy. An upper endoscopy is important because it can not only diagnose the esophageal varice, it can also be therapeutic. You also use it for treatment, which we'll go over in a minute. As far as treatment, you're first going to need to stabilize these patients. Again, when this ruptures, this is a really serious bleed. They're going to lose a lot of blood. So first stabilize the patients. Now, how do you stabilize them? Well, they've lost a crazy amount of blood. So you need to give them IV fluids, but you're not just going to put a 22, 24 gauge in their arm and just slowly drip the IV fluids. They need fluids fast. So you're going to use large bore, normally about a 14 to 16 gauge, and you're using both arms wide open. You need as much fluid getting in their body as fast as you can to to get them back to a euvolemic state. You also may need blood transfusions as well. And then once they're stabilized, there's a few things you can do from here. Now, initially, the first thing you want to do is you want to do something known as an endoscopic variceal banding or ligation. What that looks like, you're actually it's essentially just small rubber bands over the varices, and it's going to cut off the blood supply and it'll stop the bleeding. So that's what esophageal banding or ligation is known as. And that's going to be actually your treatment of choice. So once you stabilize them, if you're able to, variceal banding or ligation is going to be your treatment of choice. But there are some other options as well and some other medicines that you do need to know too. So a couple other options. One is known as an endoscopic sclerotherapy, and there's also a balloon tamponade. And what a sclerotherapy is, it's actually the same way that they treat varicose veins. So they use these sclerosing agents that are injected into the ruptured vein, and it causes local inflammation, decreased blood flow. In many cases, it may actually collapse the vein and leads to resolution of the bleed. It's second line though because it's not as effective as the endoscopic ligation. It takes a little bit longer too. And then there's also something known as a balloon tamponade, which is going to be essentially this balloon that they expand in the area that can decrease the bleeding. So these are going to be more your second line agents. Remember, again, the variceal ligation banding is going to be your first line treatment. And then as far as medications that you can give as an adjunct, so you can do this at the same time you're doing the banding ligation. Octreotide is going to be your first line pharmacological agent. So if you're giving medicine, this is going to be the medicine that you're going to give. So remember that's really important. Just like this is your first line procedure, this is going to be your first line pharmacological agent. So octreotide, you need to know that one. And the way that works, it's a somatostatin analog, and it reduces the portal venous flow. It causes vasoconstriction, decreases overall pressure, which can lead to decreased blood loss. So that's how that one works. Now, that's how you're going to treat the patient who comes in that's having this active bleed, that's in a very serious situation. Another thing that I wanted to mention too, there is a second line pharmacological agent. You can use vasopressin as well, but really octreotide is going to be the one that you need to look for on exams, and it's going to be your first line med. Now, once these patients are stabilized in the future, you want to prevent this rebleed, because this can absolutely happen in these patients that you'll fix it, but then a month or two later they have another bleeding incident where one of the varices ruptures, and then you start this all over again. So how do you prevent it? Well, the way you prevent it is going to be with non-selective beta blockers. In particular, nadolol and propranolol are the ones that you need to know. These are going to be the first line for prevention of a rebleed. So non-selective beta blockers, nadolol and propranolol is going to be your best bet for prevention of a rebleed. So there's a lot of stuff to know here. There's a lot of treatment. There's a lot of things you need to know. So I found a way that you can remember pretty much, I feel like, the 6 things that you need to know with one sentence. So like we just went over, beta blockers prevent continual occurrence of esophageal bleeds. So if you can remember that sentence, you can remember most of the things that you need to know for that. So beta blockers prevent continual occurrence of, that's just a placeholder, esophageal bleeds. So beta blockers stands for beta blockers, which is going to be your first line for prevention of rebleeds. Prevent is going to stand for portal vein hypertension. Remember, this is a complication of portal vein hypertension. Continual stands for cirrhosis, which is going to be your most common cause. That's the one you really need to know. Occurrence stands for octreotide. Remember, that's your first line pharmacological agent. Of is just a placeholder here. Esophageal stands for endoscope, which is going to be both your first line diagnosis and treatment. Remember the esophageal band ligation. And then bleeds stands for either bleeding, because this is a serious cause of an upper GI bleed, or balloon tamponade, which is one of your second line treatments. Remember, beta blockers prevent continual occurrence of esophageal bleeds. Stands for beta blockers, portal vein hypertension, cirrhosis, octreotide, endoscope, and balloon tamponade or bleeding. So that's how you remember the 6 things that you need to know for esophageal varices. Now we got a couple more things that you do need to know, not as high yield as some of the other things we already went over, but you certainly need to know them for the 1 or 2 questions you might get on them. So let's start with esophageal web. We have esophageal web, and then we have esophageal ring, which we'll be going over the last 2 things. So these are going to be different things that obstruct the esophagus. So esophageal web is going to be a thin, fibrous mucous membrane. It's going to be most common in the proximal or the upper esophagus. Clinical manifestations, a lot of patients are going to be asymptomatic, but when they do develop symptoms, what you need to know is that they're going to have dysphagia evident with solids, but not so much liquids. Now, if you remember what we went over previously, those motility disorders had dysphagia that was both with solids and with liquids. But when we're going into masses, obstruction, and things like that, not non-motility causes, it's mainly going to be just from solids. So you need to know that, because that's how you're going to differentiate on a vignette. And they're going to give you dysphagia, and they're going to say, but only to solids. Then you need to know, okay, this is something from a mass, not a motility disorder like achalasia. So esophageal web is going to be dysphagia evident with solids. So that's really important. How are you going to diagnose? You're going to do a barium swallow, also known as a barium esophagram. And this can actually be up to 100% sensitive when it's performed properly. So this is really going to be your test of choice. And you're going to see a narrowing of the esophagus in the back. So you'll see this just small area, because it's a thin, fibrous area of the mucous membrane into the esophagus. So it's just going to be a fine area you'll see on the barium swallow or the barium esophagram. You can also do an endoscope, but it's much more invasive and it's not as sensitive as the barium swallow. So really, you're probably never going to go there in real life. As far as treatment, you can do what's known as an esophageal dilation in symptomatic patients. And then after you perform this procedure, you would make sure that these patients use PPIs to prevent recurrence. And normally these patients, and about 50% of patients, if they don't take PPIs after the esophageal dilation, about 50% of them will have a recurrence of the esophageal web. So it's important to know that they do need to use PPIs after the procedure to make sure that you do prevent recurrence of the esophageal web. So there is one more thing that's really important with esophageal web, and what that is that esophageal web is one of the 3 components in something known as Plummer-Vinson syndrome. So Plummer-Vinson syndrome is when a patient has chronic iron deficiency anemia. It can lead to this dysphagia and esophageal webs. So that's one of those key things that you need to know, Plummer-Vinson syndrome. So Plummer-Vinson syndrome consists of 3 components. One obviously is esophageal web in the cervical area. Remember, this is going to be most common in the proximal or upper esophagus, which is the cervical area. So Plummer-Vinson, cervical esophageal webs, trouble swallowing or dysphagia, and iron deficiency anemia are the 3 components. So how do you remember that? You remember this sentence: Plumber's inspect. I'm sorry, I have a lot of mnemonics for this one. Hopefully it's not too much for you guys, but Plummer-Vinson syndrome is going to be Plumber's inspect clogged toilets. Plumber's inspect clogged toilets. So Plummer stands for Plummer-Vinson syndrome, pretty easy. Inspect stands for iron deficiency anemia. Clogged stands for cervical esophageal webs, and then toilet stands for trouble swallowing or dysphagia. So Plummer-Vinson syndrome is going to be Plummer's inspect clogged toilets, Plummer-Vinson syndrome, inspect iron deficiency anemia, clogged cervical esophageal webs, and toilets, trouble swallowing, or dysphagia. So that's esophageal webs. Let's go over to our 3 things that we need to know for esophageal webs. You need to know that it's a thin protruding membrane in the upper esophagus. You need to know that it's one of the 3 components of Plummer-Vinson syndrome, and you need to know that it's dysphagia to solids but not to liquids. So those are the 3 things that you really need to know. And I'm really pushing this, that it's in the upper esophagus, because when we get to esophageal rings, that's going to be in the lower esophagus. And it may seem like that's not that important, but I'll actually tell you a personal story. I had a vignette that had both esophageal ring and esophageal web in the answer, and the only way to differentiate was it stated that it was in the distal esophagus. And at the time, as a student, I could not remember which was where. So I came up with a way for you to remember it. I'll go over that in a minute. But it's important because I think I got that question wrong because I couldn't remember which was in the distal and which was in the proximal. So anyways, that won't happen to you because I'm going to give you a really good way to remember it. But so esophageal ring, also known as the Shatzki's ring, is going to be a diaphragm of obstructing tissue in the distal or lower esophagus. So esophageal web, upper esophagus, esophageal ring is going to be the lower esophagus, known as the squamocolumnar junction. So this is the way I remember it. So esophageal web, remember, is going to be the upper esophagus or the cervical portion of the esophagus. So what you think about when you see esophageal web, you think of a spider for a spider web, and you say the itsy bitsy spider climbed up the water spout. So the itsy bitsy spider climbed up the water spout, so you know esophageal web is going to be at the upper portion of the esophagus. Now when you think of esophageal ring, you think esophageal ring, remember, is at the lower or the distal esophagus. So think about putting on a ring. When you put on a ring, you don't just put it at the top of the finger, you slide it all the way to the bottom of the finger. So if you think of esophageal ring, you'll remember that esophageal ring is at the bottom of the esophagus or the lower portion of the esophagus. So you will not forget that, I doubt. I think this is a pretty decent way to remember it. So hopefully that does help you and you won't get your question wrong like I did. So that's how you remember which is which at which end of the esophagus. So esophageal ring, again, diaphragm obstructing tissue at the lower esophagus. Associated conditions, this one's really important that you don't see in esophageal webs, but esophageal ring is actually very specifically related to hiatal hernias. There's a very high percentage of patients that have esophageal rings that also have hiatal hernias. I think it's somewhere in like the 75 to 80% range. So that's really important for you to know as well. Hiatal hernias are seen in a very high majority of patients. Hiatal hernias are seen with patients with esophageal ring. So that's really important to know that you do have this associated condition. As far as clinical manifestation, there's a lot of overlap here, the same as we saw with esophageal web, mostly symptomatic, but if they do have dysphagia, it's going to be to solids. Remember, again, solids in these esophageal web and rings. So diagnosis, again, you're going to be using your barium swallow. It's going to present in a similar way. And then treatment is going to be the same as an esophageal web. It's going to be esophageal dilation followed by PPIs to prevent recurrence. So what are the things that you need to know for esophageal ring? You need to know it's a diaphragm of tissue found at the lower esophagus. You need to know that a hiatal hernia is found in almost all of the patients that have esophageal rings, and you need to know that this is going to be a dysphagia to solids, not to liquids. So those are things that you need to know for esophageal ring. And that's the second part of esophageal disorders. So I hope that helped you. As always, good luck on your PANCE, your PANRE, your EORs, and good luck in PA school. And thank you for listening.